Good morning, good afternoon, and good evening, everyone, depending on where you are tuning in from. A warm welcome to all, whether you're joining us live or will be watching up with the recording after on. We appreciate your presence and participation. We would love to know more about our diverse audience. Please type into the chat box which country you're joining us from and your professional role, whether you're a community pharmacist, a hospital pharmacist, doctor, pharmaceutical scientist, pharmacy student, or any other role in the vast healthcare spectrum. We are delighted to have you here with us today. I'm delighted to have the opportunity to have you with us today on a topic that holds immense importance to the health sector globally. Today, we will discuss vaccination, but beyond vaccinations, beyond benefits beyond specific disease prevention. I am Ozge Ozer, and I'm a pharmacist trained in Turkey, and I'm the Education and Professional Development Manager at FIP. Before we begin, some logistics to share. Please note that this event is recorded and the recording will be publicly made available on our website and also live streamed via Facebook. Please feel free to send your questions through the Q&A box. Please let us know which speaker should answer your question. We will be picking those up throughout today's session. Also, please give your feedback so we may continue to improve our digital events. This is an opportunity for me to invite you to join our global network at FIP. To have more information and become a member, please visit our website. I would also like to warmly welcome our speakers, whom I'll hand over to shortly. We have a speaker from Turkey with the new name Turkiye, and a speaker from the USA. Mine and Eric, welcome. And my dear colleague from FIP, Dalia Bajis, will moderate the event together with me. So now I would like to introduce my colleague, Dr. Dalia Bajis, who is the FIP lead for provision and partnerships. Dalia.
Thank you so much, Ozge, and welcome to everybody on the call, and welcome to our esteemed guests for today's webinar, which I trust will be a very useful and insightful one. I am delighted to be moderating this session, and I would like to thank Ozge for facilitating this presentation. Before we proceed with the program for today's event, it is with great sadness and a heavy heart that we shared with the global pharmacy community the death of our president, Mr. Dominique Jourdain, on Saturday, the 19th of August this year. On behalf of FIP's leadership and team, we would like to pay our respects to our president and colleague, Mr. Dominique Jourdain, who died on Saturday. Mr. Jourdain was exceptional advocate for our pharmacy profession, a passionate pharmacist, and a good friend to all. We will continue to serve our federation and the profession worldwide in trust, solidarity, and action as one FIP in the legacy of Mr. Jourdain. Please join us for a minute of silence to pay our respects. Thank you. Today's event will be focusing on benefits of vaccinations in older adults beyond what we know and agree on, which is the prevention of pathogen-specific diseases. But our speakers today will help us address the following learning objectives to really provide us with new insights on this topic. We will together learn about the positive downstream effects of vaccinations in older adults, gain insights into the benefits of vaccinations in reducing the risk of cardiovascular diseases and other conditions such as dementia, particularly in high-risk groups, including pregnant individuals. Learn about the multifaceted role of pharmacists in vaccination, including counseling older adults on the benefits of vaccines for overall health and quality of life. It gives me great pleasure to be handing the floor to our first esteemed speaker from Turkey, Professor Mine Tanriover. The floor is yours to introduce yourself to the audience and tell us a little bit about yourself and proceed with your presentation. Thank you so much for being with us today.
Many thanks, Dalia. It's my pleasure, and please accept my sincere condolences for your heartbreaking loss. Today we will try to focus on science behind the vaccine. So I really like to talk a lot. I'm Professor Tanriover from Ankara, Turkiye, and I'm affiliated with Hacettepe University, Faculty of Medicine, Department of Internal Medicine, and also with the Vaccine Institute of the Department of Immunization Policies. And for over 15 years by now, I have been working on adult vaccination and preventable diseases, vaccination preventable diseases in adults. Today I will try to give you a little bit of clinical perspective within the scope of vaccination. Next, please. And today's learning objectives of my talk will be to learn about the burden of vaccine preventable disease in adults, to discuss the evidence regarding the benefits of vaccinations in reducing the burden of disease beyond acute infection, and to gain insights into the benefits of vaccines to increase the quality of life and general health of people and communities. And having said that, I will start with the burden of vaccine preventable diseases in adults, and then touch upon the benefits of vaccination to protect beyond acute infection. And finally, I will touch upon the need for a lifelong vaccination approach for healthy aging. So I will start with an everyday case in the emergency room. This is Mrs. A, and she is one of the hundreds of patients that we encounter in the emergency departments every day. A 79-year-old female patient presenting with difficulty in breathing, cough, increase in sputum. And when we dive into the medical history, we see that she has chronic obstructive pulmonary disease for 6 years and also have the comorbidities of hypertension, heart failure, and she's been operated for colon cancer. She's dependent for housework and mainly restricted to in-house activities. She says that she has been admitted to the emergency room 3 times in the past year with acute exacerbations, and she reports a very recent admission to the intensive care unit. She uses oxygen concentrator, home nebulizer, and mechanical ventilation support device. Next, please. And during the hospital stay, we have started systemic methylprednisolone and just adjusted her inhaler therapy and put her on non-invasive mechanical ventilation. And as we have started methylprednisolone, diabetes mellitus just evolved, and we have put her on insulin therapy. And due to the recent hospitalization in the intensive care unit, we have started an extended spectrum antibiotic piperacin tazobactam, but her respiratory failure was imminent, so we have transferred her to the intensive care unit. And the results of the cultures that we have gathered from the sputum and blood revealed Streptococcus pneumonia. Next, please. And she has been treated in the hospital for 15 days. And on the day that she would be discharged, she said that she had an increase in cough and we just took some examples and sent her home. And afterwards, it turned out that she has a coronavirus infection as well, and she has been hospitalized again after 3 days. So just looking at this catastrophic history of just one patient, we can see what if she would be vaccinated against Streptococcus pneumonia, because when we have looked at the medical records of the patient, we have seen that she was only vaccinated against COVID-19, but not for pneumococcal infections, not for influenza, and she has not received any tetanus, diphtheria, and acellular pertussis vaccination. So next, please. We can say that the life of Mrs. A will never be the same. Not only her life, her caregivers, her family's lives will be changing ever and ever. She's been admitted to the hospital. And from the macro perspective, we can say that hundreds or thousands of patients like Mrs. A are admitted to the hospital, and this has a huge impact on the society and on the healthcare system. Next, please. So actually, these infectious diseases put patients into a vicious cycle. Just giving the example of the chronic lung disease, we know that every infection may cause a hospital admission, and every hospital admission means a loss of functional capacity. It's the functional capacity of the lung, it's the functional capacity of the muscles, and also the cognitive functions. And each time the patient is discharged home, if we can, the patient is discharged with a more severe disease, making him or her more vulnerable to future infections. So it means that more dyspnea, more reduced exercise capacity, greater likelihood of becoming oxygen and housebound, and greater decline in health status and quality of life, and being dependent more and more on the others. Next, please. So today we will be discussing about the benefits of vaccines beyond acute infection and disease and mortality, because we know that actually vaccine-preventable disease in adults have many different aspects of burden. So we are talking about the functional decline, disability, impacted quality of life, and we can spend hours to talk about the antimicrobial resistance, which is a real public health threat of this century. So we are talking about the micro and macroeconomic consequences, loss of workforce, and utilization of healthcare services, given the already overwhelmed healthcare workforce and the services. Next, please. So on the left-hand side, you can see a bubble chart indicating the mortality and the incidence burden of certain vaccine-preventable diseases. And here you can see that the biggest bubbles belong to influenza, pneumococcal disease, human papillomavirus, and shingles. But on the right-hand side, you can see that these are not the only vaccine-preventable diseases that have the impact. We can also talk about hepatitis B, pertussis, diphtheria, tetanus, measles, mumps, and rubella. Next, please. But of course, influenza is always a very good example for what a virus, what a respiratory infection can do to an adult patient. So we know that the average of like 400,000 respiratory deaths, excess deaths, are associated with influenza globally each year. And unfortunately, of these, nearly 70% are deaths above 65 years of age. So older people are more prone to infections and the consequences of these infections. And we know that even the patient just survived that episode, recovery takes time, and sometimes recovery is incomplete. We can say that depending on the results of a cohort study from Canada, so patients interviewed over 65 years of age just reported that after an influenza episode, 21.5% reported poor health and function during recovery, and 3% admitted that they have never recovered. And given the background that like up to 20% of all adults experience an influenza episode each year, this is a huge number. So we know that the burden is just beyond the mortality and the acute infection is huge. Next, please. And this mortality is sometimes partly attributable to the inflammatory processes that these respiratory diseases evoke. Like you can see here, not only influenza, but other respiratory viruses and Streptococcus pneumonia really trigger an inflammatory response that end up in myocardial infarction, cardiovascular diseases, and even stroke, some cerebrovascular events. And this risk is very much increased, especially in the first month and specifically at the first 3 days. Here you can see that after a Streptococcus pneumonia diagnosis, a patient has a 20 times increase of myocardial infarction, and this is huge. Next, please. So just expanding our perspective from the respiratory infections, I also want to ask you the question, the terminology of communicable disease of childhood is still applicable? I must admit that it's no, because when you look at the seroprevalence data and also the burden of disease data, you can see that the once accepted disease of childhood, like tetanus, diphtheria, pertussis, and measles, are now affecting adults much more than the children. And this is the graphic from the just pertaining to the results of a study from our outpatient clinic. We have just looked at the seropositivity rate of certain diseases among adults, just ranging from 18 years to 95 years. And we have seen that 90% of the adults that we have surveyed had negative antibodies against pertussis. So they are prone to pertussis infection in the adulthood. Next, please. So we know that pertussis is maybe a deadly disease for infants, for newborns, but what about the adults? So again, depending on the results of a surveillance study from a cohort of inpatients and outpatients in our hospital, I can say that pertussis prevalence was 3.5% among adults presenting with acute cough disease. And sometimes these patients may really present with devastating conditions, like given this case, a 66-year female patient presenting with 15 days of cough with paroxysms and vomiting after cough, disturbance of sleep and daily activities. And she had gastric cancer and was admitted to the intensive care unit with massive gastrointestinal bleeding, and she died in the hospital. And we would never know that she had pertussis disease if we didn't do that surveillance study. So the burden of the diseases are much more extensive beyond the current surveillance data we have in hand. Next, please. And we should also put some focus on herpes zoster, because the lifetime risk of shingles is very high, and shingles is a disease causing post-herpetic neuralgia, but it may also trigger stroke, and it may be devastating and deadly in especially patients above 70 years of age. Next, please. And it's not only the patient affected by the infection, but also the ones around the patient and also inside the patient can be affected, like the fetus or the babies of the mothers infected with influenza may develop severe congenital anomalies, neural tube defects, and hydrocephalus if the mother experiences influenza during the pregnancy. Next, please. So we can say that there are many things to talk about the vaccine preventable diseases, and we need to define our aim. Do we want to live longer, or do we want to live healthier? And do we aim to add years to life or life to years? I think the answer is living healthier and longer lives and adding life to years. So where does the vaccine stand in this point of view? Next, please. So we can just simply summarize the benefits of vaccination to protect beyond acute infection, like prevention of severe disease, complications, and acute exacerbations. But more than that, we can protect the unvaccinated population by vaccinating the community. We can prevent some related diseases and even cancer. And there are lots of societal benefits with vaccination, like ensuring the savings for a person and the society, and ensuring the economical growth, preventing development of antibiotic resistance, extending the life expectancy, ensuring safe travel and mobility that we have experienced during COVID-19, and also enhancing acuity. Next, please. And just to give you some results about the big cohort studies on the benefits of influenza vaccination, here you can see that in a big cohort of type 2 diabetes patients, influenza vaccination resulted in a 30% risk reduction of stroke and 22% risk reduction of heart failure beyond the benefits of protecting from pneumonia and influenza. Next, please. And also giving another example from influenza, this is a randomized control trial very recently reported. You can see here that patients who have been vaccinated before discharge, who had undergone some kind of percutaneous coronary intervention for myocardial infarction, influenza vaccination reduced the risk of death from all causes, myocardial infarction, and stent thrombosis by 28% during a follow-up of 1 year. And this does not, next please, this does not only refer to patients with myocardial infarction, but when you, next slide please, when you look at the cohort of healthy people, you can see that just vaccinating people with influenza vaccination can reduce the risk of first cardiovascular events and also the risk of first cerebrovascular events and associated cerebrovascular diseases. Here you can see the results of a study including over 4 million adults followed up for 10 years, and you can see that influenza vaccination decreases the incidence of stroke in the following 6 months by 22%. And if you just compare these results with the benefits of, for example, statin therapy with the benefits of acetylsalicylic acid therapy, this is really remarkable. Next one, please. And another cohort of patients who have chronic obstructive pulmonary disease, again, here you can see that during a long follow-up for 11 years, there was a lower instance of stroke in those who received flu vaccination. And the good news is that if you just have it as a habit, like the vaccination habit, the protection increases with the increasing number of vaccinations. Next, please. And there has been a recent hot topic on the prevention of neurocognitive decline with the vaccination, and this depends on the just the observation of the benefits of vaccinations with diphtheria, tetanus, poliomyelitis, and influenza to protect against the development of Alzheimer's disease. And now there are many studies, including prospective cohorts and also big databases. And here you can see the results of two examples here. So in one cohort of patients with chronic kidney disease, influenza vaccination reduced the dementia risk prominently, and it was again a dose-dependent reduction, and the vaccine effectiveness was greater in the more elderly patients over 70 years of age. And in another cohort from Taiwan, you can see that patients aged 60 years and older, you can see that there was again a dose-dependent vaccine effect, and the dementia risk was decreased by 32% with influenza vaccination. Next one, please. And another cohort here again says you that if you can just vaccinate 29 people with influenza vaccination, you can prevent 1 Alzheimer's disease. And this is, I think, a very remarkable point to just work more, because there are not proven protective or therapeutic agents against Alzheimer's, but you can see that you may have the chance to prevent some Alzheimer's cases with influenza vaccination. Next one, please. And again, just focusing on the sequelae or the complications of herpes zoster infection, the shingles infection. We can see that in the first years following the implementation of a vaccination program in England, the incidence of post-herpetic neuralgia fell by 50%. And this risk reduction was also evident for the prevention of the ischemic stroke and the hemorrhagic stroke. And here you can see that over 1.6 million people aged more than 66 years who received live zoster vaccination. Just the results show us that like 12% reduced risk of instant hemorrhagic stroke and 17% risk of instant acute hemorrhagic stroke. And this prevention is very remarkable after zoster vaccination. Next one, please. And it's not only the disease, but we can also prevent some cancers. And human papillomavirus is a known virus for causing cervical cancer among women. And here you can see the data from a big Swedish cohort who were vaccinated with the human papillomavirus vaccine. And you can see that if we can vaccinate girls before the age of 17, we can decrease the cervical cancer risk by 88%. Even those vaccinated between the ages of 17 and 30 have a 50% decreased risk for cervical cancer. So maybe you can eradicate the cancer just by using the vaccination as a community public health tool. Next one, please. And just vaccinating the pregnant, again, you can protect the baby. And here you can see, again, some remarkable results by vaccinating the pregnant women with pertussis vaccines and influenza vaccination. You can see that you can just succeed to reduce the preterm birth by 22% by the pertussis vaccination, and you can prevent the stillbirths by 45% by vaccinating the pregnant by the influenza vaccination. Next one, please. So the way forward is actually very clear. We want to age in a healthy way. We want to maintain the quality of life, the independent mobility and daily functioning, and we want to also maintain the productivity of the person and of the community. And we would like to postpone the dependency until the end of life as much as possible. And here we can see that the vaccines have a lot to do in a lifelong vaccination approach for healthy aging. So now the way forward is very clear. We can see that, next slide, please. We can see that we should make the vaccines an indispensable habit of a healthy life. And there we need the, of course, a new perspective, a new paradigm shift. So we need to have effective information and communication strategies. We need to increase the access to vaccines. We need to increase vaccine demand by the society. And we should be, as the healthcare professionals, we should be role models, and we should inform our patients and the community about the benefits of vaccination beyond the protection from acute infection. And here I think we have, as you, the pharmacists and other healthcare professionals, we have a strong power to really make a change because we are still respected and reliable people as healthcare workers in our communities. So from now on, I would like to hand over to Eric to talk about these a little bit more. And I really thank you for your patience and attention.
Thank you so much for that, Professor Mine. And before we hand over to our colleague Eric, I would like to ask you a couple of questions. Actually, one of them is burning in my mind as I was listening to your amazing presentation. Thank you so much, because you really provided us with a lot to think about from a scientific and evidence-based point of view, which I think is really important for pharmacists to really consider and hone in on as we really realize our role serving our patients with regards to vaccination and the benefits beyond pathogen-specific diseases. But the one burning question on my mind that perhaps we would love to learn from you on is why? You've described that all of these studies have shown some evidence for the potential benefit of vaccines, whether it's on reducing rates in stroke, potentially dementia, myocardial infarction. But Professor Mine, why? What is it that happens to the body that prevents or reduces the risk of all these other diseases? You mentioned something about the inflammatory response. So could you just shed some more light on this for us, please?
Yeah.
Thank you.
Many thanks. So I think this is a very important question because the science behind is really important to convince people. So we now know that with the scientific knowledge has evolved actually with the evolving epidemiology of the world. So we have seen that as the world is aging, we started to see these vaccine preventable diseases more and more among the adults. So we asked why, and we have seen that there's something we call immunosenescence, that is the aging of the immune system. And immunosenescence is something. It's a process, of course. It's not an outcome, but it's a process, and we have seen that during this process, there are some changes in the immune system and the immune response that are induced by the infectious pathogens. One thing is that, of course, the immune response that you give to the pathogens decreases by time. That's the T cell response, B cell response, your antibodies, and the pathogens that once you just recall cannot be recalled anymore. Or when you just encounter a new pathogen, you cannot develop a certain amount of adequate immunity. But on the other hand, there's something called the inflammaging. And inflammaging is that on one side, the immune response is adequate or ineffective. On the other side, the immune cells start to induce inflammation as we age. And this is very much exacerbated by the infectious pathogens that we encounter. So looking beyond the scientific evidence, like, for example, how influenza triggers myocardial infarction, this is one. The influenza itself triggers an inflammatory response, and if this inflammatory response can end up in a myocardial infarction, in the disruption of the atherogenic plaque in the coronary arteries. And on the other hand side, we now know that the immune system sometimes cannot cope with this infection, sometimes is very much activated, like we have a cytokine storm, and this just disturbs the healthy functioning of the body. And on the other hand side, we know that there is the process of inflammaging that just really harms our tissues as we age. And now scientists are just trying to discover what's behind the protective effects of these vaccines, like how can a diphtheria vaccine can protect you from Alzheimer's disease. So probably this has something to do with intervening with the processes of inflammaging and the inflammatory harm that is caused by the virus or the bacteria, whatever the pathogen is. So there's lots to be discovered here, I guess.
It's quite remarkable. It really is quite remarkable to learn about this, and what a fascinating machine is our human body and the immune response. It really is fascinating.
Absolutely.
I mean, two key words perhaps for some of our listeners to look up and learn more about is inflammaging, which is a new one for me, but also immunosenescence. So fantastic. Thanks a million for that, Prof. Mine, it's really, really remarkable. It's lovely to learn from you all of this. I do have some questions for you in the Q&A, and I believe I probably could spend a couple more minutes on addressing some of these before we move on to our next speaker. One question has come from one of the attendees. Please share your expert opinion about the present COVID-19 vaccine for the new variant of the virus declared by WHO. Is this something that you would like to comment on, Prof?
Maybe briefly, because I really didn't include anything on the COVID-19 vaccines, because the evidence is quite new to talk about the prevention beyond acute infection. So there are lots going on there, but now many experts, and I also do believe that the present vaccines, when you have your boosters like the third mRNA or the fourth, but not more than that, do really seem to be protective for severe COVID-19 infection. Because maybe we also would like to, it may be good to emphasize one thing. Actually, the rationale of vaccinating the adults is actually preventing severe disease. Sometimes you cannot prevent the infection. Like you cannot prevent influenza infections sometimes because there may be a mismatch of the circulating virus and the strain in the vaccine. But even though there is that mismatch, you can surely prevent the severe disease, the complications, the death, the admission to the intensive care unit. And the scientific evidence about COVID-19 and the vaccinations says that there is a hybrid immunity, and this hybrid immunity just provoked or evoked by the vaccinations and by encountering the disease itself is now protecting us just from the severe COVID-19 infections. So at the moment, scientifically, we can just say that the vaccines we have now in hand can protect us from severe disease, from being admitted to the intensive care unit, from mortality, if we receive the right doses of the boosters with the primary vaccination. And the mutant virus strain containing vaccines actually did not show any superior benefits when compared to the initial ones.
Thanks a million for that, Professor Mine. Lovely to learn so much from you. And we could talk to you for hours, I'm sure, about this topic. So what we will do now is we will give you a little break, and we will move on to our next speaker. And perhaps we can call upon you with some of the questions that we'll be receiving from an audience as well, and have a bit of a discussion with Eric as well on those. Thank you. So our dear colleague, Eric from the United States, welcome. And the floor is yours, Eric, to introduce yourself and to proceed with your presentation. Thank you.
Thank you, Dalia. And good morning, good afternoon, and good evening, everyone. I'm pleased and privileged to be part of this event. And before I start, I just want to pass along my thoughts, prayers, and condolences to the Jordan family and to the wider FIP family for that loss. So a little bit about myself. I am an associate professor of microbiology at the Albany College of Pharmacy and Health Sciences here in New York. I have a longstanding interest in immunosenescence. You've heard some great terms a moment ago about immunosenescence and immunoaging, how really the immune response changes with aging. Along with that interest in aging in the immune system, I have this longstanding interest both personally and professionally in RNA viruses like influenza and COVID-19. I've really carried that interest through in my profession and my position here at the college with educating students, working with colleagues that are educating the next generation of pharmacists, but also doing a lot of outreach in New York on our local public radio station to answer a lot of questions the public had about vaccines. And that's if perhaps considering a silver lining to the COVID-19 pandemic is this interest in vaccines, interest in the immune system. So I've been very happy and fortunate be able to help educate the public about both. Next slide, please. So my colleague Mine did a fantastic job explaining the other benefits of vaccination outside of preventing disease, but preventing those outcomes of infectious disease. And what I want to focus on in my presentation is how do we take that information, that understanding that vaccines provide both a primary benefit against the infectious agent, but those secondary benefits to provide, again, healthier living, longer, more fuller lives for those individuals that are older. So the objective of my talk will be to understand, again, a little bit about vaccine hesitancy, communications we can have to increase vaccine uptake, and importantly, you in the audience, the roles of pharmacists, pharmacist educators, pharmacist researchers to, again, improving vaccine uptake. Next slide, please. Again, for the outline, I've provided an introduction and learning objectives. And the three topics I'll focus on in my presentation. First is a broader discussion about understanding the drivers of vaccine hesitancy. I'll then focus on the roles for pharmacists in increasing vaccine uptake. And then with that, how do we guide conversations in the public to increase vaccine uptake? Next slide, please. So I always like to present kind of this information because I think it's broadly applicable to whatever audience I'm speaking to. And there's a quote here from the Plotkin and Mortimer book that mentions that the impact of vaccination on the health of the world's peoples is hard to exaggerate. With the exception of safe water, no other modality had such a major effect on mortality reduction and population growth. This infographic here shows, again, the burden of disease, and this is the United States from CDC data, but I'm sure this data is applicable throughout the globe, the burden of disease before vaccination in red. And then on the right-hand side, the darker syringes show the burden of disease after the vaccines have been put out in the public. So again, I think we can all appreciate in the audience here the very important role vaccines have played throughout medicine since their arrival. And again, the focus here is taking what we've learned in our previous presentation, those outside benefits, important outside benefits, but also the discussion, how do we increase the uptake here? Next slide, please. On the next two tables, what I just wanted to illustrate kind of what Mine mentioned in her talk is a number of different vaccine preventable diseases that are important for individuals that are older. So again, older, we can consider the age of 50 or above. And in most cases, people will think 65 and older. As I get closer to 50, it pains me to think as I'm approaching these age groups, But again, it's important to think about the vaccines, at least here in the CDC, and I think globally as well, that are indicated for these populations. And I just put this here, not so much to go through this list exhaustively, but just to show that, again, considering COVID, flu, pneumococcal vaccination, and zoster vaccines, there are a number of vaccines that are, again, indicated for our older population and are part of that conversation that healthcare professionals and pharmacists and educators like myself have with members of the community. Next slide, please. And it's not only older adults that we'll focus on in today's presentations, but again, individuals that have some pre-existing health conditions and individuals that are pregnant. So here again, a different table taken from the CDC listing the recommended vaccines for a variety of health conditions in adults. You can see it on the left-hand side here, focusing on pregnancy. As Amine mentioned, again, the importance of preventing some outcomes, bad outcomes with pregnancy through the aspects of using a vaccine. So again, just highlighting additional populations to focus on when we have these conversations in the wider community. Next slide, please. So think about the vaccines that are indicated for individuals. How are we doing with uptakes of these vaccines? And what these two graphs show is the uptake of the influenza vaccine in the United States by age. On the upper left are individuals aged 6 months to 17 years of age. And on the lower right are individuals 18 years and older. Now, there's a lot of information in this chart, but what I draw your attention to is kind of the trend lines. How are we doing in the US? And think about this in your own countries in terms of uptake. And what we're looking for here is the US has set up the Healthy People 2030, sorry for the extra two there, as 70%. So that's what they want the rate of vaccination across the population to be in the US. And we look at the different age groups here. You can see that in our younger individuals, just to mention these here, there was a drop in 2020 to 21, compared that to 21 to 22. So there's a bit of a drop. I won't focus too much on the impact of the pandemic on vaccine uptake, but I'm happy to talk about that more in the Q&A session. But again, vaccine uptake for flu has been below that 70% threshold for our younger individuals and those up to age of 17. Now, if we focus on the lower right, there's a bit of a more rosier story when we focus on the individuals that are 65 years and older. And as Mine mentioned, again, the burden of disease tends to be very high in those populations because of a variety of factors, such as pre-existing health conditions and a change in their immune response, both to natural infection and vaccination. The rosier picture here is that traditionally in the US, the individuals 65 years and older have been closer above that 70%. But if we look below to the other age groups, again, 50 to 65, the red line here, that line has never approached 70. So there's a lot of work to be done in that age group, in addition to the 18 and 49-year-old. I'll focus on that age group because, of course, vaccine education, when started early, can lead to acceptance and the continuation to get that vaccine as the individual gets older and it gets closer to that older age group where we worry more about the outcomes of severe disease with influenza and COVID-19, for example. Next slide, please. Now, focusing a little bit on COVID-19, I just wanted to talk about the uptake of the bivalent vaccine, the booster, if you will, in the US. Now, we'd like to see the numbers greatly increase of what they are now, but only 17% of the US population has received the bivalent vaccine. And I presume that there's similar numbers globally, that for a variety of reasons, the uptake of that bivalent vaccine compared to the primary series of the mRNA vaccines, for example, has been low. And this data provided by the Kaiser Family Foundation, actually I take that back, this is from the ACIP, some survey data that they performed, looking at the uptake of the bivalent vaccine based upon age, income, race, ethnicity, and insurance. As we're focusing on the susceptible age groups, those 65 years and older, again, the uptake of this bivalent vaccine has been greater in that population at 43%, but again, lower than we would like it to be. You can see as we go down through the age groups, the uptake decreases substantially. I want to point out too that it's not just age, that there are differences in uptake with different racial and ethnic groups within the US. So this highlights the need to target that information, that outreach that we perform in different communities. Different messages will have a greater effect in different communities. So we have to keep that in mind, both on a community level and on a patient-by-patient level. So again, looking at the flu data and our bivalent COVID vaccine data, again, we're approaching in some cases closer where we want to be on a community level for vaccination, but much work needs to be done. And part of that number that's low here could be due to, again, perceptions of vaccines and efforts we need to change those perceptions. Next slide, please. So here's the data I was mentioning before from the Kaiser Family Foundation, looking at reasons why the population wasn't getting the vaccine. And I think if you hit next slide, you might see the highlighted red line. We'll focus on the age 50 to 65 age group and age 65 years and older. What I just wanted to highlight again as some talking points moving forward as to why individuals have not yet received, go back a slide, sorry, individuals, why they have not yet received that bivalent vaccine. So some feel that they're fully protected, they don't need a booster. Again, that's also a perception that might carry forward with the flu vaccine. They've gotten it yearly, why do they need to get it next year? Along with that, they don't think they need the booster. The third one down here, 11%, 22%, is they're too busy. So life does get busy, no matter what your age is, and trying to find that time to get the vaccine. And I think, again, that's where pharmacists really play a role because of their accessibility in the community and their ability to make getting that vaccine easier to fit those individuals' time frames. Just a couple other things to think about here are side effects from the COVID-19 vaccine, and that might carry over for their perception of other vaccines, or they might think, in the last bottom two here, is that they think the disease is no longer a threat. Why get vaccinated? I don't see it on a daily basis. And lastly, too, they're not sure where to get it. So again, just some talking points moving forward to improve vaccine uptake. Next slide, please. It's important to understand that vaccine hesitancy is not an all or nothing. So it's not a yes or no. You might think of your favorite sports teams or beverages, for example, Coke versus Pepsi, right? Very distinct camps. Well, there is a continuum in the middle here for vaccines. Again, it's not all or nothing. As you can see here in this diagram, again, there's individuals that might refuse all vaccines or some, or just delay it. So we have to think about what is driving this hesitancy. These individuals typically have doubts. They may feel overwhelmed at the amount of information that's out there, what to believe. They have questions that need to be answered, and they want to figure out who is the most trusted individual to answer those questions clearly and concisely. And in some cases, they're waiting to see what their peer groups do, friends, family members, coworkers, etc. Also important too is that vaccine hesitancy is context specific. It varies with time. Right now we're in the COVID-19 era, so there's a lot of things driving hesitancy. It can change on the place, it can change on the vaccine. So it's important to think about the context when we're thinking about effective communication strategies. And it's important to understand too that individuals that get vaccinated, they still may be hesitant. So the individuals that are coming in for their yearly flu vaccine may have some hesitancy to other vaccines. So again, just stressing it's not an all or nothing game when we think about this continuum of vaccine hesitancy. Next slide, please. Now, diving a bit deeper, I like to use this analogy of a tree. Also, an iceberg works quite well. So there's things we can see on the surface. If you think a tree here, we can see the branches, the leaves. We're getting closer to fall, very pretty color changes. But below that are the roots. And that's the same here with vaccine hesitancy. It's important to understand what is driving this hesitancy on a community level, but also on an individual level. Again, as we think about targeting these communication strategies. Individuals may have had negative healthcare experiences in their past, and that's jaded their perception of anything medically related, such as vaccines. They could be influenced by their peer groups, again, coworkers, family, or friends, or social groups they're associated with on Facebook and other social media apps. Maybe that drives their perception of the world. They may have an existing lack of trust in groups such as politicians, public authorities, or medical professionals. And again, it's very difficult to break that ice, if you will. How do we get past that trust? Because a lot of the messaging for vaccines, of course, is coming through politicians, government officials, government-run facilities like the CDC, and medical professionals like doctors and pharmacists. So how do they break through that mistrust they may have in the past? Again, this is something that is somewhat found a lot in different racial and ethnic groups. They may have a sad history of health disparities, health inequities that need to be addressed before we talk about uptake of vaccines. With social media, again, we've discussed, and I've seen some in the Q&A, some questions about, again, anti-vaccine sentiments and the important, sadly, the important role social media is playing that. And along with that comes the idea of conspiracy theories that, again, that drives that as well. And with that social media, again, falling through what they see in that Twitter or Facebook or TikTok or Instagram, that's driving their attitude toward impacting their ability or inability to want to get a vaccine. Next slide, please. So think about how individuals are making their decisions. Again, placing these in context as you think of how you'll deal with the community, how you'll deal with your community, how you'll deal with your patients. First off, emotions, right? Vaccination can be a very emotional decision. The individual, again, it's important to think they want what's best for themselves and their loved ones, but they have concerns. A great example is that pregnant mother. She does not want her child to become ill with a disease, but has real concerns about perhaps the safety of the vaccine. It's a very emotional decision. Am I doing what's best for my unborn child? Time's important too. The longer it takes to decide, actually, the less confident a person may be. So you really want to use direct, clear, and quick answers to their questions. If you confuse the person more or send them off to too many different sources, they may get confused and they might just say, you know what, forget it. I don't have time to get my vaccine. I'll get it next year or never at all. Unlike with some things in life, options, more is not always better. Again, choice overload. So if the individual is given too much information, too many options, again, that can become taxing both physically and mentally. So again, you want to limit the options, limit the information you're giving. Decisions are also influenced by social norms. Again, we're very behavior-driven characters. We like to follow others at times. So behaviors, attitudes, and beliefs on a community level or a society can really determine what's acceptable. So again, thinking about what is that community you're working, what are their social norms or behaviors that might have a heavy influence on whether or not a person decides to get a vaccine. Kind of group with that is the idea of herd mentality. And our groups are very important to us. So often we'll conform to the groups that we belong to, that we associate ourselves with. Next slide, please. What I just listed here are just 8 myths that, again, I've encountered as I've gone through the community educating individuals about vaccines. And certainly you've seen very similar ones. And I've just listed these here as, again, thought points for things that are out in the public. People are concerned about myths and misinformations they're carrying with them, and get you to think about how would you address these. We could spend a whole time and talk period about trying to address each of these myths. But again, just a general thought process here of different myths such as vaccines causing autism. Can the infant immune system handle that many vaccines? Can our immune system be overwhelmed? The idea that our natural immunity, getting sick by the disease, be it measles, mumps, or influenza or COVID, that the immunity you get naturally is much better than the vaccine. Of course, the risk there is you get disease that can have severe outcomes and it could have fatal outcomes. Concerns that vaccines contain unsafe toxins. The idea that there are other approaches such as hand sanitation, hand hygiene might do a better job. That the risk of vaccination is greater than the potential benefit. That the vaccines themselves can cause infections. If we're thinking about a live attenuated versus a killed vaccine, some misunderstandings about how vaccines are produced, how safety is tested before the vaccines are brought out into the public. And then lastly, in certain places, if the disease is unseen, think about an example for polio, for example, measles or mumps, rubella, right? We don't see the disease on a daily basis as we did, again, centuries ago. So we don't need that vaccine. The disease isn't here. I can't see it. So why should I worry about getting a vaccine or worry about the risks of vaccination? So again, just some myths that I've encountered that maybe even you in the audience have encountered too. Next slide, please. Now, just some kind of thought, some discussions that you could have with individuals that have concerns about the safety of vaccines. Of course, vaccines in the US and globally as well are tested rigorously for their safety and their efficacy. When we think about some of the components, people might get a little scared, kind of like when they look at the back of a food item, you're looking at the list of ingredients, and you're very concerned about calories, protein, fat, carbohydrates, et cetera. Sometimes that similar process occurs with medicines like vaccines. But it's important to note that many of the things inside the vaccines are necessary for their production, and they're at very safe levels. Things like formaldehyde that are needed to detoxify and keep the vaccine safe from contaminants. The Mirasol, again, present in some vaccines, but not all, as a preservative. The use of adjuvants to improve the immune response, like aluminum. Antibiotics, again, to prevent contamination from microbes in the environment. And different stabilizers like gelatin. All these things might initially kind of concern someone thinking about the ingredients in a vaccine, but we conceptualize perception versus reality here, right? And this is a great slide that the Canadian government put forward to show, again, we think about these components, they might seem scary at first, but if you think about the different amounts, they're not as much of a concern. So for example, formaldehyde, yes, present in the vaccine to, again, keep it safe and inactivate viruses and bacteria that could contaminate the vaccine, but the amount present in the vaccine is 60-fold less than the time you might get the amount of formaldehyde you get in eating a pear. For aluminum, so the amount found in aluminum is vastly smaller than the amount of aluminum found in baby formula or breast milk. So for that mother that's concerned about the ingredients in a vaccine, again, the vaccine components, like aluminum in particular, vastly lower than what would be found out in nature. Next slide, please. Importantly, too, is the number of antigens. The number of vaccines has increased, but the amount of antigens has been declining. So the idea that can a vaccine overwhelm the immune system, that has changed dramatically. And you can see the number of antigens in the vaccine is as high as 200. We had the whole cell pertussis 3,000 antigens, but now because of increasing in technologies and deliverabilities, the amount of antigens is vastly less, but the vaccines can be more effective. Next slide, please. And thank you. Next slide, please. So when we think about misinformation and disinformation, again, just hitting on these a little bit, is that disinformation is the false and inaccurate information to mislead or deceive. And social media has been that primary spreader of disinformation. So personally, it makes me think, why does anyone want to do this? And there's usually a financial incentive or an attempt to make sense of tragedy or a true misrepresentation of risks. So again, something we have to combat. That misinformation is unintentional. Maybe someone is misspeaking, you don't have the scientific or medical expertise to speak about a vaccine, where disinformation is an intentional approach to mislead. So in the population level and in your patient level, you have to combat that by thinking critically. Where is the source of information? Do they have the right credentials? Is that source credible? Again, is it from a government source or a organization source? Is that content biased? Is the individual going to benefit from that? Next slide, please. So the role of pharmacists. Pharmacists, again, one of the important things to consider here is the amount of trust the public continues to have in pharmacists. And pharmacists continually rank in the top 5 of most trusted professionals. And to right here, I've taken an image from the FIP fact sheet from 2021, listing the ranking from a variety of different countries. And again, pharmacists, as I mentioned, rank very high. And on the left here is a Gallup poll from the US showing that in the US here, pharmacists rank typically 3rd behind medical doctors and nurses, but very high in the list of trusted professionals. So that's an important fact because, again, trusted, credible source of information about vaccines and their benefits. Next slide, please. In addition to the amount of trust that the public has in pharmacists tend to be the most accessible healthcare provider, that 90% of the US population is within 5 miles of a pharmacy. And I imagine globally that information may vary somewhat there. The statistics may vary, but again, globally, pharmacists are one of the most accessible healthcare providers, particularly in remote and rural areas. These pharmacists are playing very important roles in providing patient care, such as medication management, health education, a variety of preventive services. And because of that, they typically are anchored in the community that they're working in. So they've been able to establish meaningful, lifelong connections with their different communities. So again, pharmacists position fantastically to educate and improve vaccine uptake. Next slide, please. So this is I just wanted to focus on a couple of approaches for how we can start that conversation and improve uptake. This is a paper published in 2003 that was promoting what's called the ASPIRE model. And I think this is a fantastic job of explaining how we can improve uptake. So first, we want to assume people want to get vaccinated and be prepared for the questions that they may have. The ability to share important pieces of information to counter misinformation. But again, as I mentioned previously, don't overload. You want to be kind of targeted with that. Personal stories play a very important role. They want to relate to you as a provider, as a person. Have you experienced own doubts? How about family members? Why do you get your vaccine? So hearing from multiple trusted sources can really move that hesitancy needle. And again, because pharmacists, because of their trust, their accessibility, because in your training, you have a vast amount of knowledge about the what, when, and how surrounding vaccines, again, positioned greatly to move that needle. And often too, because of that accessibility and lifelong or long-lasting relationship, individuals will feel comfortable asking you questions and engaging in different conversations. And when those conversations start, again, is to respond to them and actively listen and to emphasize with the individual's concerns. Next slide, please. So some other ways to guide these conversations is, again, to initiate it, be presumptive versus participatory. What that means is you would start a conversation such as, I see you're due for your annual flu shot, rather than this open-ended question about, how do you feel about getting a shot today, or vaccines? Again, you want to go into that presumption that they will get that vaccine when they visit the pharmacy that day when it's flu season, for example. You need to tailor that conversation to the individual's specific concerns. Again, perhaps you've established a long-lasting relationship with the individual. Perhaps you know some of their concerns ahead of time. Important to ask open-ended questions. What are you worried about? What would help you make that decision? Basically, what information do they need? Is it about efficacy? Is it about the safety? Is it about, again, the benefits of vaccination for outside of preventing disease? And importantly, to listen actively and avoid body language that might convey defensiveness or just being dismissive. Next slide, please. Other things to think about as you engage in these conversations in your community and with your patients, empathy is very important. You already have that trust, maintain that trust with that individual. Validate their emotions and their concerns without validating the misinformation the individual might be bringing with them. Perhaps they've gotten from family, friends, or social media. Don't validate that, validate their concerns. Again, as I mentioned, kind of that attitudes, there's the stuff we see, but there's things that are driving their perception about vaccines. Address those. Provide clear and simple facts. Try to avoid overwhelming. There's a lot of great data out there, but again, remembering these individuals may not have that particular scientific or medical know-how to kind of dive through all that data. So find things that are clear, simple, clear, and concise. Importantly, to relate to the individual. Share your personal experiences if appropriate. Then lastly, you want to avoid the instinct to readily correct misperceptions. Instead, you want to pivot the conversation to the disease itself, the disease complications, and how vaccines can prevent that disease. And as we learned in our first half of this presentation, prevent many of those complications that can lead, importantly, to a fuller life. Next slide, please. So to wrap up, vaccine hesitancy is not an all or nothing scenario. There is this continuum that we have to work within. Hesitancy does vary across demographics, across behaviors, and a variety of different beliefs. To deal with this hesitancy, we need to tailor these interpersonal communications between healthcare providers, including pharmacists, and those individuals, in again, individual level or community level, to increase vaccine confidence. And importantly and excitingly, pharmacists are uniquely positioned to engage communities to increase vaccine uptake. So with that, I'll close, and I'm happy to take any questions. Thank you.
Thank you so much for the very informative presentation, Eric. Really, really insightful on the role of pharmacists on how to combat vaccine hesitancy, but also to really practice empathy and good communication skills, listening to the worries and concerns of our patients about vaccines, to be able to support them and combat misinformation. Thank you so much for providing us with this really great presentation. We are on the hour, but I'd like to keep us maybe for another 5 minutes to go through some of the questions that our colleagues have put in the chat box, if I may. And one of them, and I wonder if even Prof. Mina would like to jump in here, but some are asking about whether there are any disadvantages to vaccines in older adults, and what kind of advice would you want to give this particular cohort of people? We can start with Eric, and if there's any further comments
sure.
from, thank you.
I can't offhand think of any like drawback to getting a vaccine. As Minnie mentioned, again, even if the vaccine efficacy, for example, flu, is again lower, again, it's in sometimes 40 or 50% compared to the higher efficacy we initially saw with the COVID vaccines. Again, those benefits that are a little more challenging to see at first, with improving outcomes of cardiovascular disease, a decrease in Alzheimer's, as Minnie mentioned. So I can't think of a disadvantage per se. I think really what we worry with is maybe economic. Does the individual have insurance? Can they afford the vaccines? I think that's not really a direct disadvantage of the vaccine, but perhaps the cost of getting the vaccine could sometimes be a hurdle.
Or some of the common side effects of vaccines that could be shared with our patients, for example.
And I think those kind of, sorry.
No, go on. Please go on.
I mean, I would say I think that can be in some cases if they respond, if the side effects are a bit more severe, they may miss time off at work, for example, or schooling. And of course, individuals in that age group doesn't mean they're kind of without concern. Some are working, they might be involved in childcare. So that could, be a disadvantage. It might lay them low for a few days, and it might impact their life for a few days. So that's something we have to consider.
Eric, what do you think of the importance of the pharmacist role in this area, working in collaboration with other healthcare professionals, particularly with doctors, to combat vaccine hesitancy and to encourage all the other cohorts to uptake vaccines for their benefit?
Yeah, great question. Thank you, Dalia. What I've seen here in the US with my students and my colleagues is that there's a greater interaction between different healthcare providers and professionals. So pharmacists, doctors, and PAs really working together as part of a healthcare team. So I think what's nice in the students I've been teaching is that the pharmacists are uniquely set to kind of work within that. They have a great perspective on the patient. They have a fantastic perspective and knowledge on the medication. So they have a lot to provide. So at least here in the US, there's been a lot more openness, I think. There used to be maybe some closed off about the role of the pharmacist in these healthcare teams, but there's been an expansion. So I think they're bringing a lot to the table to these teams to help in those efforts broadly in that healthcare team to improve uptake.
Prof. Mene, you're a doctor sitting right beside Eric. What are your thoughts about the importance of interprofessional practice between pharmacists and doctors in this area?
Yeah, actually, we're now, for example, when we're organizing a curriculum or a scientific event, we're not talking about doctors, physicians, or nurses anymore. We're talking about healthcare professionals, because we really do believe in the power and the game-changing effect of the teamwork. So I think it's very crucial to have some kind of healthy communication with the pharmacists and the physicians, because at the end of the day, sometimes I'm talking about the community, not even the patients, but the community approaches the pharmacies first before they approach to the physicians. So it's very important to keep the healthy communication in between. And sometimes physicians can just advocate vaccination or advise on a specific vaccine, and the patient just goes to the pharmacist and asks the pharmacist, shall I really take this? The doctor just suggested it, but do I really have to take it, or is there a benefit? So it's very important to be on the same side, because if I just suggest a vaccine and the pharmacist says, oh, I don't think that is not safe for you, then everything is gone. So it's very important to be on the same side, to be speaking on the same agenda, and to build links to do this in an efficient teamwork style.
That's really important. You really summed it up nicely. Thank you for that. Any final remarks from either of you, Eric or Mine, as we conclude our webinar today? Eric, any final remarks?
Sure. Again, thank you everyone for joining us today, and thank you, Dalia and Ozer for setting this up. I think I would just say is, I think this presentation made clear the importance of vaccines for a healthy life, and hopefully the audience took with them some advice and some suggestions for how to communicate those benefits to their patients and their community.
Thank you, Eric. Mine?
Yeah, I just would like to see everyone changing the way they communicate on vaccines, because I just now see vaccines and vaccination as a very important preventive tool. And I just say to my patients that live a healthy life, just eat in a healthy style, do your exercise, and get your vaccination, because they're all the same. As we aim for a healthy aging process, then we just need to make the vaccines really an indispensable part of this preventive approach.
Wonderful. I can't thank you enough, Eric and Mine, for being with us today and showcasing the importance of vaccines beyond pathogen-specific diseases. Thank you so much for your time, for being with us today. And thank you, attendees, for being with us, all of you. I'd like to point you to our events.fip.org page if you wanted to watch more of our digital events in the FIP library. And I also would like to take an opportunity on the next slide to welcome you, because there's still time for you to travel all the way to Australia if you're in a different continent for the 81st FIP World Congress of Pharmacy and Pharmaceutical Sciences, which will be held in Brisbane between the 24th and 28th of September, with the overarching theme of pharmacy building a sustainable future for healthcare, aligning goals to 2030. Thank you so much, our speakers. Thank you all for attending. Thank you, Ozge and FIP team in the background, and have a wonderful day, night ahead. Greetings. Bye-bye.